Hi, everyone. On today's podcast, we're going to talk about the evidence on failure to progress in labor.
Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See ebirth.com/disclaimer for more details.
Hi, everyone. Welcome to the Evidence-Based Birth Podcast. Today, we're going to talk about the research evidence on failure to progress, which is the number one reason for unplanned cesareans in the U.S., and it's an extremely common reason for unplanned cesareans in many other countries around the world. For example, failure to progress is the cause of 42% of cesareans in Queensland, Australia, and 34% of cesareans in the United Kingdom. Failure to progress is probably overdiagnosed in these countries as well as the United States. In 2013, researchers published a report on more than 38,000 people who had their first cesarean, called a primary cesarean, in the U.S. during a 6-year period. The overall primary cesarean rate in this sample was 21.3%, and the cesarean rate among people giving birth for the first time was 30.8%. 1/3 of the primary cesareans in the overall sample were due to a diagnosis of failure to progress, also known as slow progress in labor. And nearly half, about 41%, of the cesareans in first-time birthing people were due to failure to progress. This means that from 2002 to 2008, about 1 in 10 of all first-time mothers in the U.S. had a cesarean for failure to progress. More than 40% of the mothers who had cesareans for failure to progress had not yet reached 5 centimeters dilation when they were taken to surgery. 6 centimeters is now considered the beginning of the active phase of the first stage of labor. So this means that many of these people were still in early labor, or maybe not truly in labor at all, when they were told that they were not dilating fast enough and needed surgery. Out of people who reached the pushing phase, or the second stage of labor, 1 in 3 cesareans for failure to progress were performed before 3 hours of pushing in first-time mothers, while 1 in 4 cesareans for failure to progress were performed before 2 hours of pushing in people who had given birth before. This is of concern because recent guidelines from the United States define, quote, arrest of labor, end quote, as longer than 3 hours of pushing in first-time mothers and longer than 2 hours of pushing in people who have given birth before, giving an extra hour or more on an individualized basis, such as in people who have epidurals, who may need extra time to push. In fact, the majority of people giving birth in the U.S. have epidurals during labor, which can lead to a longer pushing phase. A large number of pregnant people also have unplanned cesareans for failure to progress during medical inductions of labor. In one study that looked at more than 233,000 mothers who gave birth in the U.S., researchers found that half of all those included who were induced, who had cesareans for failure to progress, had not reached 6 centimeters yet, indicating that they were not in active labor yet when their inductions were labeled as, quote, failed. Now, there is no standard definition for a failed induction of labor, although there are practice guidelines from different professional organizations that list various interventions and timeframes that should occur before diagnosing a failed induction. So as we've just kind of looked at these statistics, you can see that many people are diagnosed with failure to progress before they've entered active labor or before they've pushed the length of time that current guidelines consider to be within the range of normal. It's difficult to determine how many people experience true failure to progress because so many people use so many different definitions. Globally, it is thought that about 3 to 6% of women have true, quote, arrested labor, end quote, where labor has stopped or is truly abnormally slow. Now, personally, I can't stand the term failure to progress because I think it implies that your body failed in some way, which isn't true. And I don't really like the word arrested labor, which has kind of negative connotations as well. Now, arrest is kind of the medical term for stop, so it kind of means stopped labor. But arrested labor tends to be the more accepted term among researchers and clinicians now instead of failure to progress, because failure to progress is very vague and subjective, while there are more defined criteria for arrested labor these days. Interestingly, you can look at when people give birth at home with midwives in the U.S. In those cases, failure to progress is the most common reason for a transfer to the hospital from a planned home birth. However, rates of failure to progress in planned home births are very low. In one study with nearly 17,000 planned U.S. home births, only 4% of women were transferred to the hospital for failure to progress. A 4% rate of failure to progress is much lower than what we see in hospital settings in the U.S. For example, in the state of Michigan, one study found that 20% of all hospital births are diagnosed with failure to progress in the year 2006. Unfortunately, if someone lives in a developing country, you might be at risk for something called neglected obstructed labor. This is when labor either stops or goes on for much too long and is left untreated or, quote, neglected, end quote. In developing countries, neglected obstructed labor causes 8% of all maternal deaths and is a cause of stillbirths, newborn deaths, and maternal fistulas. A fistula, spelled F-I-S-T-U-L-A, is a hole between the vagina and the rectum and/or bladder, usually caused by the baby's head pressing on this area for days during a neglected obstructed labor. The end result is that if the woman survives a childbirth, she may leak urine or feces through her vagina, causing great physical and emotional suffering and seriously limiting her ability to function socially and economically for the rest of her life when unrepaired. And most fistulas go unrepaired in developing countries. Fistulas occur in 0.01% to 0.08% of births in the developing world, but are almost unheard of in developed countries. So why do so many people in some countries, such as the US and the United Kingdom and Australia, have unplanned cesareans for failure to progress? Well, until recently, most women in labor were held to a standard called Friedman's curve, named after Dr. Emanuel Friedman. Friedman's curve is a graph that care providers have traditionally used to define a, quote, normal, end quote, length and pace of labor. Friedman's curve gives first-time mothers about 14 hours to go from 0 to 10 centimeters dilated, and it gives experienced mothers who've given birth vaginally before only 8 hours. If a cervix does not dilate according to this schedule, you may be assigned a diagnosis of failure to progress and taken to the operating room for a cesarean. Where this came from is really fascinating story. In 1955, Dr. Emanuel Friedman of Columbia University published a study that described the average amount of time it took people to dilate by centimeter during labor, based on his observation of 500 white patients at a single hospital. Until that time point, doctors had simply published research studies that described the total length of labor. Dr. Friedman went one step further by plotting their labors on a graph, and then calculating the average length of time it took to dilate each centimeter during labor. This graph became famous and was known as Friedman's curve. Although it was published in the 1950s, Friedman's curve still served as the basis for how most physicians around the world defined normal labor until very recently. In other words, most care providers use this graph to dictate how best to manage someone's labor. However, this all began to change in the early 2010s. In 2012, the U.S. National Institute of Child Health and Human Development, the Society for Maternal Fetal Medicine, and the American Congress of Obstetricians and Gynecologists held a workshop aimed at preventing the first cesarean. The summary stated that too many people were being inaccurately diagnosed with failure to progress. In 2014, the Society for Maternal Fetal Medicine and ACOG, the American Congress of Obstetricians and Gynecologists, released a consensus statement called Safe Prevention of the Primary Caesarean Delivery. In this statement, they redefined normal and abnormal labor and stated that Friedman's curve should no longer be used as the basis for modern labor management. In 2017, ACOG also released a further statement reaffirming the importance of using the updated definitions to limit intervention during labor and birth. Dr. Friedman, now in his 90s, is still criticizing the new guidelines and editorials, one published as recently as 2020. In 2015, Dr. Friedman stated that Friedman's curve has, quote, served many women well for decades, end quote, and that, quote, a time-tested approach is now being abandoned in favor of new recommendations that have not been validated, end quote. Although some hospital systems have already adopted the new consensus recommendations, it's going to continue to take time for care providers around the world to change their practices. You might still run into some physicians and facilities that lean more towards the numbers published in the Friedman's curve. Now, keep in mind that the study that Dr. Friedman carried out to design his Friedman's curve focused on 500 first-time mothers who gave birth at term in 1954. More than half of them had forceps used during delivery, and only 1.8% gave birth by cesarean. Twilight sleep was common practice at the time, and 23% of the women were lightly sedated, 42% were moderately sedated, and 31% were deeply sedated, sometimes, quote, excessively sedated with Demerol and scopolamine, meaning that 96% of the women in the Friedman's curve study were sedated with medications and probably didn't even realize that a doctor was running around their rooms, checking their vaginas to see how dilated their cervix was on a regular basis. The average age of these women was younger than people giving birth today, and women back then tended to weigh less as well. Dr. Friedman found that the average length of time it took to get from 0 to 4 centimeters was about 8.5 hours. And then once women hit 4 centimeters, their labor sped up, which he called active labor. And at that point, they dilated an average of 3 centimeters per hour until they reached 9 centimeters. Then there was a little slowing down between 9 and 10. But overall, it took about 5 hours to get from 4 centimeters to 10 centimeters. And the average length of pushing was only about 1 hour. Again, probably because most of these people had forceps used on them. At the time, Dr. Friedman was describing labor in a way that had never been done before. However, modern researchers have come to the definitive conclusion that we can no longer apply Friedman's curve to labors in today's world. Now people have epidurals. They're not given twilight sleep or sedation. Pitocin is used much more frequently. Birthing people today are older and tend to weigh more on average. And giving everyone a forceps delivery is no longer routine practice. And all of these factors can impact the length of labor. So what are some things that could make you more likely to have a longer labor? Everyone can have different factors that can lengthen or shorten your labor. Epidural use lengthens both labor and pushing on average. Being 35 or older, having your labor medically induced, giving birth for the first time, and having your baby have a posterior positioning of their head, such as OP or sunny side up, can all lengthen labor. Also, some things like being confined to bed, not being adequately hydrated, being a survivor of sexual assault, giving birth to twins, having premature rupture of membranes, and maternal health problems such as gestational diabetes, hypertension, or preeclampsia, or being pregnant with a big baby can also lengthen labor. There are a few factors that lead some people to have a shorter labor. Not having an epidural during labor or pushing can shorten the length of labor on average. Pitocin augmentation or acceleration can shorten labor. Having given birth before shortens labor. And using upright positions during labor and pushing can also shorten the length of labor. Interestingly, artificially breaking the waters or having your membranes ruptured on purpose has not been shown to decrease the average length of labor, even though it's used for that purpose quite frequently in the hospital setting. Researchers have also compared the muscle DNA of people who have had cesareans for labor arrest versus those who had cesareans for other reasons. They found that some people have different genes for muscle contraction, muscle inflammation, and how muscles might respond to low oxygen levels during contractions. And the results from this one study published in 2013 by Chima-Saithong suggest that some people who have labor arrest may have some genetic differences that affect the muscle cells of their uterus. So we know now how long it used to take people to dilate during Dr. Friedman's time. But what about today? Well, for people who go into labor on their own without the help of a medical labor induction, labor tends to last much longer than what Dr. Friedman graphed in 1955. In one important study published in 2010 by Zhang and Landy et al., researchers looked at the labor records of more than 62,000 people from 19 hospitals across the U.S. Women were included if they gave birth vaginally at term to a single baby who was positioned head down, if the babies were born healthy, and if the labors started spontaneously, i.e. were not medically induced. Most of the people in the study routinely had interventions during their births. Overall, about half of them had their labors augmented or sped up with Pitocin, and 80% had epidurals, which is pretty representative of most people in the U.S. today. The researchers found that on average, people in this study did not rapidly dilate starting at 3 centimeters like Dr. Friedman saw back in 1955. Instead, it appeared that active labor started for most people at around 6 centimeters. This was true for both first-time mothers and those who had given birth before. although experienced mothers tended to dilate faster once they reached active labor. The average time it took to dilate during active labor was about 30 minutes for each centimeter, which ended up being faster for experienced mothers. The vast majority of people, 95%, took less than 2 hours to dilate 1 centimeter during labor. Interestingly, researchers found that before 6 centimeters, many people went long periods without any dilation, and this was within the range of normal in the sample. For example, on average, the sample took 1.8 hours to get from 3 centimeters to 4 centimeters, but the top 5th percentile of the sample, which is still in the range of normal, took as long as 8 hours to get from 3 to 4 centimeters. On average, people in the study took 1.3 hours to get from 4 to 5 centimeters. But the top 5th percentile took 7 hours to get from 4 centimeters to 5 centimeters. All of these women went on to give birth vaginally to healthy babies. When it came to pushing, or the second stage of labor, first-time birthing people pushed for an average of 1.1 hours with an epidural and 0.6 hours without an epidural. At the very extreme end of normal, some first-timers, the 5th percentile that pushed the longest, pushed for 3.6 hours with an epidural and 2.8 hours without an epidural. Experienced mothers had much shorter pushing phases. On average, they spent less than 30 minutes pushing with an epidural and about 15 minutes without an epidural. Other researchers have also examined the length of labor in modern populations and confirmed these findings from Zhang, that labor lasts longer for people today than it did in that study that Dr. Friedman carried out in the 1950s. In one study carried out by Neal et al. In 2010, researchers combined the results of 18 studies from 1990 to 2008 that reported the average length of labor among 7,009 first-time mothers who went into labor on their own. In these studies, active labor was defined as having contractions and being at least 3 to 5 centimeters dilated. Many of the studies in the review included birthing people who received Pitocin augmentation, artificial rupture of membranes, and epidurals for pain relief, all common interventions in the U.S. today. Researchers found that for these thousands of first-time mothers, the average length of active labor was 6 hours, with people dilating an average of 1.2 centimeters per hour during the active stage. These results were quite different from what Friedman found more than half a century before. In 1955, Friedman described 1.2 centimeters per hour as, quote, the lowest acceptable rate, end quote, of cervical dilation. But among the subjects in this study, 1.2 centimeters per hour was actually the average rate of dilation. Half of the women in the study dilated slower than 1.2 centimeters per hour, and half dilated faster than this. In other words, what was considered slow labor in Dr. Friedman's day has actually been found to be the normal rate of dilation today. Unfortunately, Dr. Friedman's curve has created an expectation around the world that first-time mothers should dilate much faster than they actually do on average. Applying these standards in hospitals around the world has meant that many people have been diagnosed with failure to progress when what they were experiencing was actually normal. In those cases, failure to progress could have been more aptly termed failure to wait. And most of us today know multiple people, friends or family, who've had a cesarean for failure to progress due to applying these unfair standards to labor. However, some people think that long first-stage labors are harmful, and we should avoid them at all costs, including Dr. Friedman, who is continuing to publish editorials about why we should still be using Friedman's curve. We found 3 recent studies on the risks of longer labors, and each study used a different definition of long. The findings were mixed. Based on these studies, there does not appear to be any difference in infant mortality if people have a first-stage labor that is abnormal by Friedman's standards. All 3 studies found no increased risk of postpartum hemorrhage, although one study found people were more likely to be anemic and require a blood transfusion postpartum. Only one of the 3 studies looked at NICU admissions and found a higher risk of NICU admission, and 1 out of 2 studies that looked at APGAR scores found a higher chance of APGAR scores. I detail these studies in our signature article at evidencebasebirth.com/failure to progress. The authors' names are Shiner, Chang, and Hamilton. Some people may also be curious about the risks of pushing for longer periods of time. I also summarize the research on this topic in our Failure to Progress article at evidencebasebirth.com/failure to progress. And it's actually such a complex topic, and there's so much research on prolonged second stage of labor or pushing phases. We actually published a separate article just looking at that. And you can find that at evidencebasedbirth.com/prolonged pushing. That's /prolonged pushing. But to kind of give you a quick overview of what the observational research has found on longer pushing phases, in the observational studies that have been published on the length of pushing, there are several findings that seem to be consistent across studies. First, researchers have repeatedly found that people with epidurals have much longer pushing times than those without epidurals. For example, one study found that half of all first-time mothers without an epidural gave birth by the time they reached 47 minutes of pushing. But when they looked at first-time birthing people with an epidural, it took 2 hours of pushing for half of the people to give birth, and the other half took longer. When they looked at the 95th percentile, the length of the second stage by which 95% of those pushing had already given birth, this is considered the upper range of normal. 95% of first-time mothers without an epidural gave birth within 3 hours and 17 minutes, while 95% of first-time mothers with an epidural gave birth within 5 hours and 36 minutes. It's encouraging to note that in research studies, the majority of people with longer pushing times still had vaginal births. However, evidence shows that the longer someone pushes, the more likely it is that you'll experience a cesarean birth or a forceps or vacuum-assisted birth. Researchers have consistently found that longer pushing times are related to higher chance of maternal complications. For example, first-time mothers with an epidural who push for more than 3 hours have postpartum hemorrhage rates of 5.9% compared to 3.7% in those who push less than 3 hours. Rates of infection of the uterus also go up with prolonged pushing from 0.4% up to 1.2%, and the risk of having a severe tear or third or fourth degree tear also goes up from 5.8% to 10.1%. However, it's not clear whether the higher rates of these complications are due to the prolonged pushing phase themselves or because of the higher rates of intervention that can accompany a longer pushing phase, or both. For example, the higher use of forceps or vacuum could contribute to the higher rates of severe tears. For babies, longer pushing times have been related to higher rates of NICU admissions, low APGAR scores, and other newborn health problems. However, the overall rate of these complications is low. For example, in one study that looked specifically at experienced mothers who'd given birth vaginally before, babies born after 3 or more hours of pushing had a NICU admission rate of 5.4% compared to 2.9% in babies who were born after less than 1 hour of pushing. Several researchers stated that their study results support the most recent guidelines, giving people additional time to push. They state that because rates of vaginal birth are high and overall complication rates are low, longer pushing times should be permitted. One researcher pointed out that any decision about whether to push for longer periods of time or not should take into each person's unique benefits and risks. For example, you could consider how well the baby is handling the pushing, how far the baby has traveled down into the pelvis and descended, and if the baby is continuing to descend with pushing efforts or not. I've only been able to find one randomized controlled trial on the length of the pushing stage. This is a small study with 78 women published by Gimofsky et al. In 2016. It took place at a hospital in Pennsylvania. People could be in the study if they were having their first baby and if they had normal fetal heart monitor results during labor. If a participant reached the 3-hour pushing phase mark with an epidural, they were randomly assigned, like flipping a coin, to either an extended care group or a usual care group. The people in the extended care group were given the option of continuing pushing for 1 more hour in line with the new ACOG guidelines. Women in the usual care group were given no additional time to push. In both groups, if your time was up, you gave birth either with cesarean or by vacuum or forceps-assisted delivery. It's important to note that the study only included people with epidurals because the people without epidurals all gave birth before 3 hours of pushing or declined to be in the study. So everybody in the study had a medically managed labor and birth. All of them had epidurals, about half of them were induced, and most of them had Pitocin going to augment labor. Most women in the study were also instructed to delay pushing for about an hour because they did not have an immediate urge to push once they were fully dilated. And that delay was included in the total time they were given for pushing. Typical practice in this hospital was to instruct people who were pushing to hold their breath while pushing, and most people pushed while lying on their backs, about 93 to 97%. The researchers found that people in the extended time pushing group had a much lower cesarean rate than those in the usual care group. The cesarean rate was only 19.5% in the extended time pushing group versus 43.2% in the usual care group. The researchers estimated that for every 4 people who receive an additional hour during pushing with an epidural, 1 person would avoid a preventable cesarean. So we've talked about the research evidence on how often failure to progress occurs, the history of it, and what studies have shown about the normal length of labor today, as well as the benefits and risks of having a longer pushing time. But what are the evidence-based definitions of normal and abnormal labor? Now, because of all of this research that's been coming out over the past 10 to 15 years, the new definitions of normal and abnormal look quite different than the old definitions that came in of Dr. Friedman's studies. Table 1 in our signature article at evidencebasebirth.com/failure to progress compares the old and new definitions of labor dystocia, failure to progress, active labor, first stage labor arrest, second stage labor arrest, and failed induction of labor. For example, labor dystocia is an old term that means slow, abnormal progression of labor. Today, the term labor dystocia is not used in the new guidelines. The old definition of failure to progress is that it's a vague term that can mean the lack of progressive cervical dilation, the lack of descent of the baby's head, or both. The new definition is that this term is no longer used. Instead, the guidelines state things like a prolonged early phase should not be an indication for cesarean, and slow but progressive labor in the first stage of labor should not be an indication for cesarean. Active labor used to be defined as the cervix reaching 3 to 4 centimeters dilated. Today, guidelines suggest that cervical dilation of 6 centimeters should be considered the threshold for active phase for most people. Thus, before you reach 6 centimeters of dilation, you can't apply standards of active phase progress. And you should not diagnose someone with arrested labor if they have not yet reached 6 centimeters. Today, guidelines recommend that the definition of first stage labor arrest only happen if someone has reached 6 centimeters and your water has broken, plus you have one of the following. 1, there's been no cervical change for 4 or more hours of adequate contractions, or 2, there's been no cervical change with at least 6 or more hours of inadequate contractions with Pitocin. Also, for the second stage labor arrest, the new guidelines from ACOG and the Society for Maternal Fetal Medicine state that there's no specific maximum length of pushing time that can be spent pushing. Labor arrest in the second stage can be diagnosed if there's been no improvement in descent or rotation of the baby after 4 or more hours in first-time mothers with an epidural, 3 or more hours in first-time mothers without an epidural, 3 or more hours in experienced mothers with an epidural, and 2 or more hours in experienced mothers without an epidural. Trained physicians can also consider manual rotation of the baby's head prior to moving on to the use of vacuum or cesarean. What about failed induction of labor? Importantly, the term failed induction only applies to pregnant people who never reach the active phase of labor, or 6 centimeters. In other words, a failed induction means that the induction methods failed to get you into active labor, not that your body failed or that a cesarean had to be performed, although a failed induction commonly leads to a cesarean. If someone says an induction, quote, failed, but you are 6 or more centimeters dilated and you meet criteria for labor arrest, the more appropriate diagnostic phrase would be labor arrest in the first or second stage. The cesarean rate for people who are induced, as well as the rate of failed induction, varies greatly from hospital to hospital and provider to provider. This means where and with whom you are giving birth with an induction has a huge impact on whether your induction leads to a vaginal birth or a cesarean. Strong recommendations from ACOG and the Society for Maternal Fetal Medicine in the U.S. state that cesareans for failed induction can be avoided by giving more time in early labor, up to 24 hours or more with regular contractions, and requiring that synthetic oxytocin be given for at least 12 to 18 hours after breaking the waters before diagnosing failed induction. So if maternal and fetal status are reassuring, it is premature. It's too early to call an induction failed if you haven't yet broken the waters and you haven't been given synthetic oxytocin for at least 12 to 18 hours after the waters have been broken. Researchers have found there are no harmful effects to the baby if a laboring person is given more time to labor with an induction, as long as both the mother and baby are doing well. In multiple studies in which researchers have examined long inductions and infant outcomes, they found no link between longer early phases of labor during an induction and newborn health. There are, however, some factors that can increase the risk that an induction might not work. If your cervix is not ripe and you're electively induced, one study found that you're 3.5 times more likely to have a cesarean compared to people who went into labor on their own. So having cervical ripening before the induction is really important for helping prevent failed induction. Another really important factor that can increase your risk of a failed induction is the hospital where you're giving birth. One study in Portugal found that the cesarean rate for people who were induced was significantly different from hospital to hospital, even after taking into account the number of high-risk people at each hospital. The percentage of first-time mothers who had cesareans with a failed induction ranged from 27 to 55% for elective inductions and 35% to 56% for medically necessary inductions at different hospitals. This just demonstrates how different hospitals can use very different criteria to diagnose a failed induction. And you may be at a hospital with care providers who are significantly more likely to diagnose a failed induction. So if you're having an induction or you might have an induction in pregnancy, I highly recommend talking with your care provider. You could say something like, out of the last 10 people who you induced, how many of them had a cesarean? In the United States, Moroccan et al. Published an example of a U.S. hospital with a very high cesarean rate for people who were induced. At this large hospital in New York City, first-time mothers who were induced at 41 weeks with an unripe cervix had a failed induction rate, i.e. a cesarean rate in that case, of 49%. Finally, it is likely that there is a strong physician or provider effect when it comes to the risk of cesarean with elective induction. At one large urban hospital in the US, for example, Luthi et al. Looked at all of the first-time birthing people who gave birth to head-first singleton babies over a 2-year period. When they looked at all the different risk factors for cesareans, the individual physician in charge of the care of that patient was one of the strongest predictors of whether or not an elective induction would turn into an unplanned cesarean. Why is it that different hospitals and different providers can have different cesarean rates with inductions or with different rates of failure to progress? Well, in that joint workshop that I said took place in 2012 with the National Institutes of Health and Society for Maternal-Fetal Medicine and ACOG, their summary declared that non-medical factors play important roles in cesareans that are performed for failure to progress. These may include time limits on the length of labor and delivery scheduling issues and room availability, operating room staff availability, and the limited space and resources to support long labors and long inductions. These are all factors that could encourage providers to label or mislabel your labor as failure to progress or even as arrested labor. Other factors that can lead to too many failure to progress diagnoses include care provider fatigue, high workload, and sleep deprivation. In fact, research has shown that cesarean rates for failure to progress go up when the care provider knows that they can go to sleep after the birth or when they could be doing office hours instead of participating in a long labor and vaginal birth. The workshop summary also stated that there are financial incentives to diagnosing failure to progress. They said on page 1191, quote, "Financial incentives and disincentives related to work efficiency and staffing workload may also tilt the scale toward more liberal performance of scheduled cesarean deliveries, given the time required to monitor a complicated labor. There is a financial disincentive to persevere when labor does not proceed efficiently, or if borderline fetal heart rate patterns are present. Evidence suggests that doctors who are salaried and participate in profit sharing, thus reducing the financial incentive to limit the time spent managing labor, have lower cesarean rates," end quote. So to stop overdiagnoses of failure to progress, the following recommendations were made from that workshop. Care providers should use the proper current definitions of labor arrest and avoid using the vague term failure to progress. Birthing people should be given adequate time for both labor and pushing, and adequate time is much longer than what has traditionally been allowed in the past. Induction should only be labeled as failed after at least 24 hours of Pitocin, plus your waters being broken if possible. And this clock should not start until after cervical ripening has been completed. Birthing people with an unripe cervix should not be induced unless the induction is medically necessary or cervical ripening can occur. And each care provider should receive feedback from their hospital on how often they improperly diagnose labor arrest or failed induction. I've only been able to find one research study on what happened after care providers stopped using Friedman's curve, but the results were really encouraging. Ragusa et al. Carried out a prospective study in 2016 in which 419 Italian women were enrolled. Half of them were given standard care based on Friedman's curve. The other half were given a new model of care that followed the ACOG and SMFM new consensus guidelines. With the old care model, not only was Friedman's curve used, but food was banned, laboring people were restricted to bed and told to push on their backs. With the new care model, Friedman curve was used as a screening tool, but providers were instructed to have more patience with labor and to carry out further assessments before they decided on surgery or medical intervention. In addition, laboring people in the new model of care were encouraged to walk during labor and to push and give birth in the position they found most comfortable. They were also given access to food and drink, and the care providers used a standardized protocol to diagnose fetal distress. The Italian women who received the old model of care with strict adherence to Friedman's curve had a cesarean rate of 22%, compared to 10% cesarean rate in the people with the new model of care. The people in the new model also had fewer interventions overall. Fewer had Pitocin or their waters artificially broken, and they had better newborn outcomes in the new model of care. Fewer babies had low APGAR scores or low umbilical cord pH, 0.5% in the new model versus 2.3% in the old model. Now, some of you may be worrying if you happen to be diagnosed with failure to progress or arrested labor, are there any other options besides having a cesarean? First of all, it's important to understand that you need to make sure that the proper definitions for labor arrest are used. Evidence suggests that if you are in normal spontaneous labor and you've not been induced, and if you're less than 6 centimeters dilated and your labor has stalled, then this is not true labor arrest, and you should simply receive supportive care. Supportive care in that situation where you have a prolonged early labor may mean continued observation, Pitocin augmentation if needed, or discharge from the hospital. Discharge is often recommended if labor has stopped, your waters are intact, and both you and baby are in a good condition and you've not yet reached 6 centimeters. If first-stage labor arrest is diagnosed in someone after they've reached at least 6 centimeters, some medical options include breaking the water, Pitocin augmentation, and allowing you to continue laboring as both you and your baby are healthy. Obviously, there are some situations of labor arrest where a cesarean can become necessary. Based on a thorough review of the evidence, authors Gore and Romano, in their book Optimal Care in Childbirth, suggested using 4 preventative Ps to deal with some outside factors that may cause labor to slow down in the first place. These Ps include permission, physical environment, practices, and people. Permission means that birthing people should have permission to move about, eat and drink when they want to, and use whatever positions they find comfortable. Natural behaviors should not be restricted, quote, unless there is a compelling medical need to do so and the person has made an informed choice to comply with the recommended restrictions, end quote. For physical environment, the birthing space should be large enough for you and your support team. There should be private places to walk, tubs and shower for water therapy, and birth balls and other props that encourage upright positioning. You should have a say in the physical aspects of your environment, including lighting, sound, and the people who come in and out of the room. The third P is practices. Practices that restrict mobility, such as being hooked up to the continuous electronic fetal monitor or IV fluids, should not be used unless medically necessary. If these practices become necessary, care providers should try to lessen their impact on your mobility. For example, portable electronic monitors could be used so that you can remain mobile instead of requiring you to lay in bed, or a peanut ball could be used to help position you if you have an epidural. Finally, the last P is for people. Care providers should be supportive, non-judgmental, and respect your autonomy. Birthing people should feel free to express their emotions or needs without fear of being pressured or coerced into meeting hospital or provider expectations or preferences. So, what's the bottom line after reviewing all of this research evidence on failure to progress? Well, the old definition of a normal length of labor that's been used since the 1950s is obsolete. There are new evidence-based definitions of normal labor, labor arrest, and failed induction, and those should be used now. The vague term failure to progress has no place as a medical diagnosis. As long as both you and your baby are healthy, and as long as the length of labor does not qualify as an arrested labor, people should be treated as if they are progressing normally because there's a wide range of normal. If you're being medically induced, you should be given more time to complete the early phase of labor, as it can take a really long time to get through early labor with an induction. Importantly, 6 centimeters, not 4 centimeters, should be considered the start of the active phase of labor for most people. And caregivers should keep in mind that normal early labor before 6 centimeters sometimes includes a resting period in which there may be no change in dilation for hours. Some people may decide with their care providers to delay hospital admission until they're in active labor. It is thought that if more care providers use the new evidence-based definitions of labor arrest and failed induction, we would see fewer of these diagnoses, and hopefully a lowering of the cesarean rate in a safe way. In our childbirth class at Evidence-Based Birth, we teach this information about failure to progress, and we give some suggestions for preventing preventable cesareans for failure to progress. One thing we encourage all of our childbirth class students to do is to keep the one-page failure to progress handout with them during labor. Now, it's in their workbook for their childbirth class, but all of you have free access to this one-page handout if you just go to evidencebasedbirth.com/failure to progress and download the free handout using the blue button at the top. That way, you'll have the true definitions of labor arrest at your fingertips. We also suggest to our childbirth class students that if they have an extra long labor or a labor that seems prolonged, to remember that there are many alternatives and options that can be used to cope with that longer labor, including Pitocin augmentation, physical activity, walking and mobility, patience, rest, and helping fix the positioning of a baby that's not in the best position or optimal position for birth. We also encourage our childbirth class students to make sure they're given sufficient time and support for early labor, also during the pushing phase, especially if you have an epidural, and also make sure you're given enough time and support for a labor induction. And it's also an option to avoid going to the hospital in very early labor, as sometimes that can stall or slow down your progress. I hope that this information in this podcast was helpful for you. And again, don't forget to download your free handout at evidencebasedbirth.com/failure to progress. That's it for this podcast. I'll see you next week. Thanks, everyone. Bye.
Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasedbirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.